So we said at the very beginning this was going to be kind of a journey, right? Kind of, accompany you into the journey and path towards patient fibrillation. So after the real blood pressure now, well, we will be, I'm going to be taking you in my office, in a kind of surgery. And I would say that I've been doing this job for a while, and I can tell you that I learned that every single person enters in a surgical consultation room as they have goes 100 miles an hour. And people are overwhelmed about fears, uncertainties, questions. And I would hope that the next couple of minutes will try to shed some light and give an answer to all those inquiries. The moment you are, first of all, yes, the moment you are like, why do I need this? Am I the right candidate to do it? Do I have to do that? And what they actually going to be doing on me? And is it going to be a sort thing? I'm going to be in pain? How long am I going to be blocked in the hospital and so forth? So let's try to navigate all this together. And first of all, surgical ablation. So as Dr. Nashville was mentioned, electrophysiologists with the catheters, they do ablations, so lesions inside the heart. The surgical ablation is considered as something which is applied outside the heart, which we call epicardium, so outside the heart. And who should really get this type of procedure? Well, this is a complex chat, let's say. This is the complex chat, I was saying, and we really need to be mindful of all the words about the Ashford and the previous speakers, because we've been noticing how the treatment of fibrillation is very complex. There are multiple types of fibrillation and multiple triggers. We've been discussing just now about the mitral valve. Some people have probably the mitral valve and then they develop the fibrillation. Sometimes it's the other way around. It's atrial fibrillation that creates a problem in the mitral valve. Some other people just have atrial fibrillation for some reason. So each of the type of atrial fibrillation, as I said, paroxysmal, persistent, whatever, and each of the triggers might require a different treatment. And to be honest, out of all the studies that we've been showing, many of people could do very well just with medical therapy. But the actual decision making on what to advance is much more complex. In other words, let's say this is not a one-size-fits-all approach. Really it's not, because we need to come together and describe and thought about what is the best option in each individual person. And I'm going to talk to you, I'm actually like teacher to the real books, and the one that we as physicians we look at. Those are called guidelines, right? It's a really scary document, it's like 65 pages of things, in which basically they tell you, I mean, how the large studies that have been performed, work on the indication, as we say, like, when somebody needs something. And as you can see here, I mean, it was symptomatic persistent outstanding behavior. We remember the talk about like, sometimes they keep occur. And multiple times when despite all the medication, despite all the medication, AFib tends to come back. Or in the case that after a number of ablation, there is still a limited success and there's still AFib recur. Or there is another very wide topic that we're not going to touch today because it's going to be too long, is that when people need other type of surgery, for instance, with valve release or with coronary surgery, and in that same occasion, what we call concomitant ablation can be performed. Now, because I'm Italian, I also looked at the European guidelines. I was heavily on them. And as a matter of fact, it's pretty much the same story. Because Winston actually started to think about surgical ablation. Basically, when the AFib is when it keeps being there, when medicine are not working anymore, when sometimes the ablations are not working anymore, also, most importantly, is also when it affects your daily life. And this is when, as we mentioned, there's a lot of discussion among physicians because I'm sorry, very honest. Because we never seen that And one of the things that Rashid has told you, so like failing of the mitigation or previous controversial that didn't work, he said that all those are the right reason to go for evaluation. As a matter of fact, those are also the right reasons to go towards a surgical ablation. So how do we decide? And are those surgery and cardiac ablation in conflict? The answer is really not. This is not a conflicted situation. It's quite the opposite, though. It is a interaction. It is like a collaboration, because sometimes surgery not really is something that you will reserve as a last resort. Sometimes it can be performed earlier, and this really depends on the conversation and the single characteristic and features of each of the patients. And I'm going to tell you why atrial fibrillation surgical ablation can work. So as you can see here, we are doing ablation from the outside of the heart. And as Dr. Ashler showed, the anesthesiologist can do ablation from the inside of the heart. So now imagine if you make a call, if you combine what can be done inside the heart, so with the catheter, we what can be done from the outside of the heart with the surgical ablation. The results, when you combine the two things, are definitely better. And definitely better because we tackle the same problem two different perspectives. And this is not just me saying this, this is out of large randomized clinical trials that have shown that when we combine the two procedures, so we do what is called a hybrid surgical ablation, the results are much better. So if you only do the cardiac ablation and then you add on top of it the surgical ablation, the results can really shoot up, the success rate really shoot up. So once again, it's not 100%, and we're going to be talking about this. It's not 100%, but it's better. Now, let's review the reasons why these combined ablation can work. This is a map as Special can show you. So this is a map of the caloric activity of the population. And then when we put the ablation, obviously, everything becomes great. But still, there's something little here and there. And then if we need some time, then all of a sudden, AFib recurs. So that's why if we add surgery, this can be total silence. Or the other way around. Sometimes we can see a situation like this. We can perform surgical ablation and then let our friends and colleagues anesthesiologists to finish up the work in order to obtain the full silence. Now, let me make you understand the reasons of all this, because this has a very important anatomical implication. One of the problems with the endocardial ablation, so the inside of the heart, is that some areas of the heart cannot be reached very well, and in particular the back of the heart. As I showed, those are the common areas where all the vein comes by, or the blood comes back from the lungs, and it really connects into this big chamber, which is called left atrium. Now, the back of the heart, the back of this left atrium, is sometimes difficult to reach with the catheter, meaning that at the minute they do the ablation, seems like this is okay, but then some part are missing. So let's see how it is. So this is the actual left atrium. This is like the back of the heart. And this is the area which is difficult to reach. And then I want to point out something that we haven't really touched a lot through the research video. But this thing is very important. This thing is called left atrial appendage. What it is? It is basically a residual of our endurance life. It's something that stays there, and in our adult life doesn't really serve much. I think it's very long to solve. Yeah, so it doesn't really serve much in our adult life. But what can happen is that because it has this, there is peculiar shape, like a little band, this becomes a site where clots can form. And when do they form? Well, when there is atrial fibrillation, because when there is atrial fibrillation, the heart has a squeeze very well, and there is a lot of stagnant blood. And stagnant blood transforms in clots. And then these clots start to accumulate. And what can happen is that one of those clots basically can liberate into the situation and give a story. And that's the reason why I invited here Dr. Allen, because I want you to understand all this. And that's the reason why we can also address the left atrial appendage, trying to click it, to close it, so that anything was there in terms of growth can stay there, or anything can stay there, or nothing can come in. Now, what surgery does for the ablation? So what we do, we go into the back of the heart, as you can see. So we can go on the back of the heart and apply energy to make those lesions. To make the same lesions that can be done from the inside of the heart, but we do it from the outside of the heart. Okay? And we can start to see this is the lines that we want to use for instance. And what we do, we put it on the heart and make all these progressive movement, so that all this part of the heart is eventually, from the electrical perspective, silenced. What can we do for the left atrial appendage? So we can enter into the chest and see this left atrial appendage. This video is also very nice because it shows that also the left atrial appendage is creating problems. Now, what we do, because each atrial appendage is different, we don't have the same shape. Some people have different form, different size, different morphology. So we need to size it a little bit, try to understand how big is it, where is it. And then we can come in with something that can go in very slowly, okay? And we try to tease this tissue in, and then what we do, we close it, we clear it, so that nothing can come in and nothing can come out. Now, how do we do all this at UC? And here, I kind of like to say that we use a kind of a different approach, an approach that we call the patient-specific inline-based surgery. Why? Because we have a strong research department, we have a strong collaboration with the radiology department, and also the bioengineering department. And what we can do is to get images from the same patient, from the exact patient, from the CT scan that you guys have done in the past. And then take this information and bring it into a 3D printing so that we can 3D print your chest. And once we have the 3D printing model, the reconstruction of this model, then we can look at it. We can see how to enter into the chest. We can see what is the morphology of the left atrial appendage. We can see what are all the, let's say, intricacies anatomically wise. And this is what basically we can obtain. We have a 3D reconstruction, a 3D model, and we can look at it. We can move it, we can see inside, we can see outside. Now, since today we have a very special patient, I brought you a very special model. This is the model that we use to run your surgery. Okay? So as you actually extract the your chest, and so what we are aiming here is at the left atrial appendage. We want to see all this, and we can see here is line, and the rest of the parts that we want to make foundational is the left atrium, the back of the left atrium. So then what we can do with this model is that when we have a clip, we can imagine in which side of the chest we are in. We can imagine that this is going to be in this position or in that position, and then we can go in here. So this has facilitated a lot our surgery, especially because in this way we can pre-plan minimally invasive approaches, because we don't want to open the chest too much, and we want to compete a little bit. We want to be like our friends radiologists. Our friends radiologists do your procedure, and the day after you are at home. So in surgery, historically, people with surgery has been always in the hospital for a long time. And we want to make sure that you're not sore and you can go home earlier and get back on track and back on your daily life. I give you on that your living room. But beside that, those easy measures, of course, one thing with these labs are crazy, is actually showing the different type of approaches that can be used to enter the chest and do this appendage treatment and do the left the left wall ablation. And one way is to go from the side of the chest. One way is to go from the front of the chest, just here and below the breastbone. However, here you see we've been, and this is basically the approach from the front of the chest. However, here you see we've been pioneering a different approach, and this approach is based on the use of the robot that you can see here. And the reason is mainly to try and have a smaller incision, but most importantly, because the robot can help us to really see the heart and do the remote magnification and allow us to reach in parts of the body that are more difficult to reach otherwise. And since we're here, I'm going to show it to you. So, first of all, this is Laura. This is my robot. We call it Laura. And we call it Laura because in one of the first cases we've been doing, music is always on in my OR. And that famous song about Laura was there going on, and we just decided that this was going to be her home. And so, how are you? You see the screen there? Apparently everybody can see it at once. So, you see my little hands are moving? Okay, so this is the inside of the heart, right? And I can show you a little bit more. So, this thing has been opened here, but this is the sac where the heart is, okay? You can see the sac has been opened, right? And if you go a little bit farther, you can see the left little appendage, the thing that we were, willing to clip. And you see how beautiful it is and how easy it is to get in and manipulate it. Well, this facilitates a lot to clip the appendage because the appendage, you see, needs to be clipped here. And now we can do this with simply cables. Now, we said that we also need to go on the back of the heart, right? So, what do we do here? I have 3 hands, so one I can use it. And this can be my assistant, right? And then I can start to go on the back of the heart, you see? Because I can go very easily in and even farther. And even farther. And this is actually the part of the heart, this part here. You see this bit? This is the back of the left atrial appendage. And that's the one that we need to burn and ablate. Can you see how close is it? Can you see how easy I can see things and I can go exactly where I want, avoiding any other further issues and troubles, and avoiding ablating things that I don't want to ablate. And then when I'm done, I just simply come off the thing and I close up everything. So as you can see, this can help dramatically to do operations that in the past were considered much more invasive. And now you will for sure say, okay, but this is sore, this is still sore, this is not going to be pain. Don't switch to the normal thing. Yeah, so hey, pain for surgery has always been a big problem, okay? And where did it come from? Pain comes from the nerves, and especially in these particular scenarios, when we enter the chest, pain can come from the intercostal nerves. Here in this vignette, they say that 60% of the patient on the blood test is experience chronic nephritis. Okay, yeah, but this is chronic. This is in the long run. What we are really looking at is now is after the day after surgery. How can we block that, and how can we make sure that your joint is better? Now, what we can do is to go in where your nerves are and freeze them. And the reason is that freezing them basically allows the flow of information of pain to be frozen. But in this way, you're never going to be experiencing pain as such. But what happens is you're going to be experiencing numbness. And numbness, and numbness will allow you to navigate towards the initial phase of the post-operative recovery, because it's a numbness that extends in the space of 2 to 3 months. And then progressively, because we have only burned and frozen one part of the nerves, now we haven't frozen the part of the nerves that regenerates, then the nerves will progressively regenerate, much as it happens with a snail when you cut the tail, right? It starts to regenerate, and regenerates about 1 millimeter per day. So very slow growth. Meaning that at the minute you are able to freeze one of your nerves, you will have numbness for some time, roughly 2 to 3 months, and progressively the nerves will regenerate and will get a new sensation to the pain, to the body. Has been shown to be a very effective way of dominating pain surgery, because we can easily understand when you do this in the lateral part of the chest, or when we enter into the front of the chest, we will still do the same. In other words, we can make this surgical access basically painless. Of course, not at 100%. So still there is some degree of pain, there is some degree of discomfort. But as anything in life, you want to come with the edge of things. You try to put something that has a very high risk or is very uncomfortable to something which is more comfortable and tolerable. So with this, I will say, first of all, I want to emphasize that once again, long good period, but gosh, there's still probably one for weeks on the back. This is a team sport, okay? This is not a single person working. You know, is a big soccer game, not just something happening. So soccer, but apart from that, as you can see, you know, I have a wonderful team. Those are the nurses, the PA, and those are my partners in the cardiac surgery team. Dr. Lewis, which has been the surgeon of one division we just met, and Dr. Lester, and Dr. Panza, and myself. He's the cardiac surgery team, and we're all able to deliver these therapies for you. So, well, for the moment, I would say thank you, and I think we can move to stop because we have please. They only done down here. These are basically you know, we are somewhat pioneering this system. In the region there are other units having also the robot. This is something that has been a little bit our you know need, but it's not rocket science. It just requires because of this robot really makes things difficult easy. I mean, this location versus say Westwood. Oh yes, yeah, only good. We only can go cardiac surgery patient in this location. Might be this some stuff, but you said sometimes you do it for dual. Why would you do one like the other? Is this the more extreme as opposed to the outside, as opposed to the one? Is how we saw in the neurocostume is that sometimes when you only do an ablation which is the inside of the heart, sometimes the ablation cannot be totally successful because either some parts of the heart are left behind because they are difficult to reach, or the entire wall of the heart, like it's not totally upgraded. Because you can upgrade it like imagine like a sandwich. You can upgrade it from one side of the sandwich and also from the other side of the sandwich. And if you're big only from one side, sometimes you cannot get the full thickness of the wall. And in that particular circumstance, everything you can do further. The concept of this is that we can tackle the wall of the heart from the inside, brush very well hand, and from the outside. And the combination of the two things, provide better outcome and more long-term results. Now, the timing of one and the other, so should we do first one and first second, it's still very debated and really depends on each individual patient. Normally, the normal stream is that somebody gets refilled, then they will get a cardiologist for instance, and then the refill comes back, and then they try evaluation. And then after the evaluation, we need to decide should we go on the other side of the or should we try again another location? And all those information, once again, is not one size fits all. You cannot put it on one single facility because the patient area, maybe the surgical location, the one from the outside, is probably best for the individual. In other ones, it's better to still try another couple of operations inside the heart before going on the outside.
I understand that I had ablation first, but then I had to have the version afterwards because the version didn't work. It came back. So, but with the aversion, it stopped it. But when you do something like this and you do the modeling, you do scan the CT scans and all those kinds of things to get this to this point.
This is actually thermal patient. That chest is exactly the functional for a chest.
Yeah, that's our.
So, and that's the beauty of it, because we are not using just a model, we are using the person. Is patient specific.
How many seasons you do a month, approximately?
Yeah, we would like to do more of them because those patients are not that frequent. Like normally the amount of patients that arrive to the surgical department is limited in comparison to the amount of patients that go into the normal ablation. And that's what we are trying to battle here, okay? Because every single time we talk about surgery, everyone gets scared because we think in big complication and everything. But at the minute we are able to shape these complications and make these procedures very similar to the ones that can be done from the inside of the heart, then this is another very valuable tool to help out. And once again, this is not a matter of one versus the other. It's not like a conflicting situation. It's a collaborative situation because multiple times what we do, we have Dr. Rashidar doing one part of the procedure and I'm completing the other part, or vice versa. That's the reason why I have Dr. Rashidar on my speed dial. Because we found a lot.
And we're gonna support the performance.
Wow.
Good, okay, so, my questions. I have second about